Good morning. So I have about 5 slides or so from the last of the cytogenetics that I wanted to cover. And so I'm going to start with that, and then we'll go into genetic screening after that point. So where we left off yesterday was just beginning the idea of when a person has an inversion in a chromosome. And remember that the inversion is when there are two breaks on a chromosome. And then instead of that piece of the chromosome exchanging with a non-homologous chromosome, it simply inverts on that chromosome. A really good question is, how could something like that happen? And we don't really have a good sense of the mechanism. So sounds like a cop-out, and I guess sort of it is, but it's just not simply understood how that process could occur, unfortunately. So this is the kind of thing that we see, therefore. So these are two homologs, and we see the sister chromatids of each of those homologs, and then there's kind of a haplotype that's given on this chromosome. We have A, B, C, D, E, F, G. And then this boxed region represents the sequence on this particular homolog that has been inverted. So one of the first things that's important to realize is when you're dealing with this is that it's not going to be on both of the homologs. It's going to be on one of the two homologs. So the homolog on the right has the normal haplotype in terms of order of sequences. The one on the left has the inverted sequence. This could be considered a balanced rearrangement as well. Is there gain over loss of genetic material? No, it's just simply that it has been changed around in terms of the order of these sequences. There can be two different types of these inversions. And I think it's valuable, and I put this into the objectives as well, to be able to distinguish between these two. And it's pretty simple, I think, is paracentric. Essentially what we're saying here is a paracentric inversion is acentric. Centric is referring to the centromere. So acentric means does not include the centromere in the inversion. And then pericentric, the I, you can think of it as inclusive of the centromere. So not involving the centromere, involving the centromere. Paracentric includes the centromere, paracentric does not. So this particular one would be a pericentric inversion. Sorry, a paracentric, because it does not include the centromere. This is an acentric inversion, because the centromere is up here. So typically the person who has this doesn't have any recognizable phenotype at all associated with it. Occasionally these breaks can interrupt genes, but that's a rare occurrence as opposed to the norm. So most of the time they don't have a problem with this. The problems, again, come in with respect to offspring. And so they result in an inability of these chromosomes to pair properly, and that can cause problems during then meiosis. So this is a rather complicated figure, which is the norm lately, complicated figures, in terms of what is happening. So what we're saying here is we have an inversion on chromosome 8. And this inversion is essentially at the two breakpoints, where this is the region that has flipped. So this chromosome has the normal haplotype, 1 through 8 in the right order. This one has a paracentric inversion that has flipped this entire region. So we go 1, 6, 5, 4, 3, 2, 7, 8. So what's going to happen during meiosis 1 during germ cell development is the chromosomes, the homologs, are going to synapse. How do these two chromosomes synapse? Because if you line them up, large portions of these two chromosomes don't match up. You'll see 3, 5, 4, 3, 5, 2, etc. So the chromosomes have to do some gymnastics, basically, in terms of synapsing. And they will do these gymnastics, where one of the chromosomes, the one that doesn't have the inversion, is shown on the outside, and then the one on the inside that has the inversion forms a loop. And that loop then allows synapse between homologous regions. So if you look at these two chromosomes, then the 3s line up, the 4s line up, the 5s line up, the 6s line up, the 7s, so on and so forth. It gets a little funky down here, but hopefully I'll try to work this out in terms of their numbering. So this is what's going to happen during meiosis. So the next thing that happens during meiosis is recombination. And this is where problems come in, is during recombination, in terms of what happens to the recombined chromosomes. So in this diagram, with this arrow, we're saying that recombination has occurred between the region 6 and essentially between region 7, between region 6 and region 7. And this is within the looped region. So if the crossover occurs within the looped region, it can cause problems in terms of the new chromosomes. And so let me show you what happens. So let's start with the blue chromosome. If we follow this one along, starting here, we go region 1, 2, 3, 4, 5, 6, 7. We will then cross over, and then we will continue on from here. Now, this 2 is here, okay? And essentially, the rest of that portion is this, region 1. They've kind of stretched this out a little bit to be able to show this in greater detail. So you would say, well, there's a lot more DNA here than there is shown here. And yeah, it's a flaw in terms of how they diagram this. But essentially, what I want you to see is we go through region 6. So in this chromosome we're going through, we come to region 6, we cross over to the gray. And then once we do that, we continue on, and that's region 1. So, in other words, this chromosome is now, in terms of haplotype, 1, 2, 3, 4, 5, 6, 1. If that chromosome gets passed on to the next generation, that chromosome 8, it will be essentially duplicated for any genes in region 1, and it will be deficient in any genes in region 7 and 8. The other parent gives a normal chromosome 8, so they would essentially be kind of quote-unquote trisomy for certain regions and monosomy for other regions. Would that produce a phenotype? Pretty likely it would. Then if we look at the other chromosome, so we'll start right here, and this is region 1, essentially. And remember, this one has the inversion in it, so the next region should be 6. So here's region 1, and then 6, and so on. But if we do this, we go region 1, we come to here, we cross over. And so that means we've crossed over into the blue. And then we continue, where we have 6, 5, 4, 3, 2, 1. And that is then going to be shown over here. Oh, no, sorry, I did that wrong, because that's a crossover region. Let's start here, at this bottom, region 8. So here's where we want to look. We have region 8, 7, and then 2, 3, 4, 5, 6. We cross over to the blue, 7 and 8. And so that's what this chromosome is, where it's duplicated for region 7 and 8, and it's deficient for region 1. So it's the exact opposite of what this chromosome was. It is duplicated for region 7 and 8, and it's deficient for region 1. If that chromosome is passed on, it can be problematic because it will probably produce a phenotype, could produce lethality, increased infertility as well. Next question. I didn't put this into yours, but it's an important question. Crossover outside the inverted region. Let's say these two chromosomes synapse, and the crossover is here. The recombination is there. And you'll notice that's outside of the inverted region. This chromosome 7 and 8, this chromosome 7 and 8. That will be an okay recombination. And so there will be no gain or loss of genetic material if the recombination occurs outside of the inverted region. So two things to take from that is the larger the region that's inverted, the more likely there's going to be a problem in the next generation. Because the greater region means there's a greater likelihood of recombination within the inverted region. So if it's in a smaller inversion, maybe it's not going to cause a problem. So doing the cytogenetics and seeing just how large that inversion is, that can have value as well. And the greater the inversion, the more likely there is that there's going to be problems associated with it. Okay.
Just a general question. Could you make the argument that two smaller inversions would be even more dangerous because of like the twisting and writhing that needs to go?
So could you make the argument that if you had two inversions, it would be a worse situation? And the two inversions essentially occupying the same amount of material as the one inversion. Tell me again why you think so. So, yeah, I suppose that's possible. So the answer was that, let's say that you have two inversions in a chromosome, and you could even ask, could the chromosomes physically create that combination, where they could actually synapse? And it's possible that they might not be able to do that. I haven't heard of a situation where an individual had two inversions in a single chromosome, but I think, yeah, I would agree with you that that could be something where those two chromosomes are simply not going to synapse. If that's the case and they don't synapse, what is probably very likely is non-disjunction, where the two chromosomes don't separate properly at that point. Okay. Any other question on that? Okay. A couple of things, I've already mentioned a few of these, but just want to highlight as we wrap this up, is trisomies and monosomies again. So amongst conceptions that have been analyzed for humans, trisomy for every single chromosome except for the Y chromosome has been observed. So it is possible for any of the autosomes and the X chromosome to be present in a conception as a trisomy. All trisomies, no matter what they are associated with increased risk of fetal loss. And so the likelihood of spontaneous abortion will go up with any trisomy. For these, and these are the ones to really be familiar with, that are associated with live birth are 21, 18, 13, and the X chromosome. So those are the four that we can see in trisomy conditions amongst live offspring. Now, you may have a conception that survives to term, let's say trisomy 8, but it's never going to survive longer than that. So the incidence of trisomy conceptions in general increases with advanced maternal age. So across the board, all the trisomies. So pregnancy loss due to trisomy is then naturally going to follow. It will increase as well with advanced maternal age. So one good question is why? Why are these chromosomes involved? The X chromosome we've already discussed, and its incomplete X inactivation as the mechanism for why that chromosome is more compatible with life. But this is an interesting figure. It's showing chromosome size on the X-axis and the number of genes on the Y-axis. So chromosome 1, for example, is the largest chromosome, and it is very gene-rich. When we come down here, and remember this on the Y-axis, the number of genes, getting down into really known numbers, we see the Y chromosome, small with very few genes. And then next is chromosome 21, and then 18, and then 13. So the ones that are associated with trisomies are the ones that have the fewest number of genes. 22 is lethal. Trisomy 22 is lethal. Trisomy 21, not necessarily lethal. And there's a significant difference. 22 has a lot more genes on it than does chromosome 21. So the question then is kind of a chicken and egg thing. Do these chromosomes have fewer genes because they are involved in trisomies more often? And so there has been a drive to reduce the number of genes on these chromosomes? Or the trisomy is increased because it's tolerated, because they do have fewer genes? And the answer to that question is not known at this point in time. But certainly, these three chromosomes, 21, 18, 13, plus the Y, are reduced in terms of the number of genes on those particular chromosomes. Monosomies. Monosomy can occur for any of the autosomes as well. It is always an embryonic lethal as well. So monosomy for any of the autosomal chromosomes is not going to be compatible with life. The only one and we talked quite a bit about this one, is monosomy for the X, 45X, which is Turner syndrome as well. Turner syndrome is compatible with life, but greater than 99% of all conceptions that are Turner syndrome, that are 45X, result in spontaneous pregnancy loss. And so the vast majority of Turner syndrome conceptions are going to result in loss of the pregnancy, even though it is compatible with life. So this brings up the idea that there's probably mechanisms of sensing these abnormalities. There may be subtle changes in terms of cell proliferation, cell division, et cetera. And we don't fully know why. But it's definitely been shown that these are greatly enriched in terms of loss of the pregnancy. 60 to 80% of these are paternal non-disjunction, and again, involving the separation of the X and Y. And probably that doesn't have the same fidelity as separation of two X chromosomes. And about half of all surviving Turner syndrome offspring are mosaic. And mosaicism, a couple of points there. First, mosaicism. Essentially what we have is a mixed population where some of the cells in the individual has 46 chromosomes and some of the cells have 45 chromosomes. And those mixes can be very different from one potential Turner syndrome to the next. So the phenotype can range quite a bit. Another is that anytime you have a mosaic, you are dealing with a mitotic error as opposed to a meiotic error. So a mitotic error means after there has been fertilization of the egg and we start cell proliferation. And then there's a loss of a chromosome during mitosis in a cell. And so it's not something that occurred in the sperm or the egg. The last thing I'll point or give you is that essentially what's happening here is we have cell division, mitosis. And in one of those two new cells, it loses one of the X chromosomes. And so then it goes down to 45X. So there's two ways that this could happen. One is that it's in a female. She's 46XX, and then she also has a population that's 45X as a result of loss of that chromosome. What if this happened in a male embryo? It starts off as 46XY, and then it loses the Y chromosome in a percentage of cells. Then you would have a mosaic that is some cells are 46XY, some cells are 45X. The cells that are 45X will, essentially, they lack the SRY gene. They will contribute to female development. The 46XY will contribute to male development. So, is this individual male or female? And they can be ambiguous. So an individual who presents at birth with ambiguous genitalia, there can be a number of reasons for that. But one possible reason is that they are a mosaic for Turner syndrome, where there are a mix of cells that are both 45X and 46XY. It's a rare occurrence, but it is possible, and it can be seen. I think that's my last slide for that one. Any questions there? Before we move on. Oh, yes, one last slide. Quickly go through this. You can read through this. I don't have to read through it for you. When is it advisable to consider a chromosome evaluation? Essentially doing some of these tests, some of these karyotype analysis, et cetera. And person with ambiguous genitalia certainly is one of those. One that I would add here is female with 2 or more miscarriages. That really should be on the list. If a female has multiple pregnancy losses, we want to see if there's a chromosomal basis for it as well. So the last two of my lectures, genetic screening and diagnosis. And hopefully, if I do this well, we will finish on time, even though I have way too many slides. So objectives, I won't spend a lot of time on this in terms of reading through the objectives. Hopefully, you get a sense for my objectives at this point in time. Moving along, readings, you got it. So objectives. Why do we do screening? And we'll start with prenatal screening. We're essentially prior to birth. So we are trying to assess the kind of chromosomal constitution of the conception. And oftentimes the basis or the reasons for prenatal screening are misunderstood by the population. It is not the purpose of this type of prenatal screening to try to reduce the incidence of genetic diseases or syndromes at birth. Many, many people believe that that's the primary goal of this type of screening, and it is not. The primary purpose is education, I would say, information for the couple or the female in order to make informed decisions, to be able to make the very best decision that is acceptable to the female or the couple. That's what we want to do. Inform them about their risk for genetic disease, about birth defects, so that they can make those informed reproductive decisions. Some of those decisions obviously can be very difficult decisions to make. And so having misunderstandings with respect to risk does not allow people to be able to do that, to make the very best decisions with the best information that they have. And that's what we want to do. So benefits of prenatal screening. First one that I have here is provide a level of reassurance. Not absolute reassurance, but a level of reassurance when a screening test is negative. Studies have been done looking at these types of prenatal screens, and the average is about 80% of the time a prenatal screen comes back negative. So 80% of the time, the test gives reassurance, as opposed to increasing the angst, I guess you could say, of the individual. So that is a big one. Second, provide an accurate estimate of actual risk. People misunderstand genetics a lot. And when they do, they tend to overestimate what the risk is. And so in order to make a well-educated decision, they need to really have a good understanding of what the actual risk is. And so prenatal screening helps to provide a more accurate estimate of risk. Provide options for how to manage that known risk when the test results come back positive. So examples of this. One, electing not to proceed with pregnancy. So an understanding of, this is our risk, and based on that risk, we're going to decide simply not to proceed. Another is pregnancy termination for an effective pregnancy. I know this is obviously a controversial area, complicated area, but the things that I would say at this is that, at least at this point in time, this is a legal procedure in this country. And parents can make these decisions to elect not to continue with the pregnancy. Obviously, it can be a very challenging decision. But I'd also add that the decision should be theirs to make with respect to the best education, the best information that they have available to them as well. Choosing other routes. In vitro fertilization, IVF, followed by pre-implantation diagnosis. We haven't talked about pre-implantation diagnosis, but we will as we go through. And so this would be a way to reduce that risk. Another, allow physicians to plan management of a high-risk pregnancy. For example, with Down syndrome, one of the things we said with trisomy 21 is that oftentimes during development, they will develop very serious cardiac anomalies. If the physicians know that the pregnancy is trisomy 21, they can make sure that everyone is available at that time to be able to manage those cardiac risks. And so it allows for a safer pregnancy and a safer delivery because we're aware that this is the case. And so this can be a value. I have heard many, many times where someone will say, I would never terminate a pregnancy, therefore, there's no good reason to do prenatal screening. That's a very common view. And hopefully people can see that there's a lot more to this type of screening than just that, than just pregnancy termination. And this would be a good example, where if your conception is a much higher risk, and even for the mother possibly, then we can plan and we can prepare as a result. This one, is important as well, to allow families time to prepare for the birth of an affected offspring. If you know months ahead of time, you can come to grips with it, as opposed to after the birth, when, if you're a parent, all hell is breaking loose at that particular time. You're not sleeping at all. You have a new baby in the house. That's not the time to have to come to grips with this idea that things are not quite right with that offspring. Much better to learn this earlier, to understand this fully in terms of going forward. I give an example for myself, a rather mild one, but it's an example. My first daughter was born with a ventricular septal defect. So she had a hole in her heart, which was actually pretty large. Fortunately, it closed on its own, so she didn't have to have surgery or anything. And we didn't learn the VSD until her first wellness visit. You know, her heart was checked in the hospital after she was born, but the blood pressure is so high and the heart rate is so high in a newborn that you can't hear a VSD, the murmur associated with a VSD. But the first wellness check, then it was apparent. And I'll never forget when the doctor essentially put the stethoscope in, put the stethoscope down on her little chest, and you could visibly see him jump as soon as he heard it. You know, he recovered quickly. I give him credit for that. But clearly he heard it immediately. And then that was when we learned that there was something that wasn't right. And one of the things that happens, you know, one of the worst situations is to have children if you're a geneticist, to tell you the truth. It's just awful. Because you think, okay, these are all the things that can go wrong. How could it possibly go right? You know, and so as soon as the baby's born, you're counting, okay, 10 toes, yeah, okay, nothing in terms of abnormalities at all. And then you let your guard down. So we had let our guard down. Everything is okay. Then, first wellness check, everything is not okay. We were not prepared. So if we had known ahead of time, it would have been far, far better for us. And so that can be a major advantage as well. Screening tests and diagnostic tests. Very often, these are confused by physicians and by the lay public as well. It's really helpful. I think in yours, I say essential. I changed it to helpful because these tests are getting blurred a little bit, and I'll describe that as we go on. So it can be helpful to understand. Screening tests are not meant to be diagnostic. I'll say that again. Screening tests are not meant to be diagnostic. They represent a reassessment of risk based on the application of that test. Okay, this was your risk before the test. This is your risk after the test. It doesn't mean that it is positive in terms of the child having this particular disorder. Lots of people misunderstand this. They can be followed up with better tests. Usually the screening tests are very imperfect tests, but they're applied to a very large group of the population. And the primary purpose is to identify those individuals in whom additional follow-up tests may be appropriate. And those follow-up tests can give a far more definitive yes or no answer. So based on the screening test, here's what we should do next, for example. So the screening test should never be the ending point, unless the parents choose to have that case. So these types of tests should always be voluntary. You know, it's up to the parents. Whether or not to proceed must always be essentially the decision of the family. So couples need to be informed. What are the benefits of doing this type of screening? What are the potential risks? What are the limitations of these tests? If it comes back positive, what does that mean to a physician? What does that mean for you as a parent as well? How should you react if it's positive? Those are the kind of things that should be done before the testing is even done. Healthcare providers shouldn't pressure a family to proceed with a screening or follow-up testing after that. And again, it should be voluntary. Your triple screen came back positive for Downs, so we need to schedule you for an amniocentesis. This is, as close as I can remember, an exact quote that was given to my wife with our second daughter. So let's unpackage this a little bit first. So your screening test came back positive for Downs. Did it? What is implied there? What's implied there is that your conception is positive for Down syndrome, for trisomy 21. It is not. The screening test is a reevaluation of risk. Based upon that test, our risk went from 1 in 270 for a trisomy to about 1 in 80 for a trisomy. Did our risk increase as a result of the test? Yes. Well, I mean, our understanding of the risk definitely increased. Is it positive for Downs? No. There's a 79 out of 80 chance that the test result is not a true positive. That was totally misunderstood by the pediatrician in terms of this. So what happened was my wife immediately called me, told me this. I called the physician, said, basically, what the hell are you doing? Can't believe that this is what you would say. The comment back from the pediatrician was, and I think I said, why don't you explain this correctly? In as nice a way as I could at the time. And the response was, well, people just don't understand. And I'm sure she could visibly hear my head slap at that point in time. People can understand this. They just don't have the necessary background to understand it. So it's the job of the pediatrician to do the work to make sure that the person understands it. She was not willing to do any of that work. Shouldn't be employed in that job as far as I was concerned. She was not our pediatrician after that day, I can tell you that. We moved on. The other part of this, so we need to schedule you for an amniocentesis. Who just made that decision? She did. Should she be the one making that decision? Absolutely not. So there's a much better way to do this. So I kind of appreciate this because it's such a good teachable moment. I'll never go back and tell her that I appreciate that she told me that, but it's very valuable. And by the way, our second daughter did not have a trisomy condition either. So it was a quote-unquote false positive, but it's still valuable. And people say that as well. The vast majority of these are false positives. Why do the test? Because it identifies that population in whom we should perhaps do additional better tests to be able to identify when these conditions occur. So, methods for prenatal screens. Prenatal screens should be minimally invasive, as safe as possible, as cheap as possible, because we want to apply it to a very large population. So the risk is very, very low, both for the mother and for the fetus, these kind of tests. Typically offered to all females during pregnancy, and we'll talk about the times as we go through as well. High false positives is kind of the nature of these tests. So false positive essentially means that it's a positive test result in someone who does not have that particular disorder. So the physicians need to understand that there's a high false positive frequency and not incorrectly kind of say what the test means when it really doesn't. So that's, I think, a very important point to keep in mind. Prenatal diagnostic tests. This would be the next step after a positive prenatal screen. Usually a more invasive test usually has a greater risk for the fetus or the mother or potentially both, but higher sensitivity and specificity. A higher ability to tell, does the conception have this particular anomaly or not? And so usually a more expensive test, a longer test, to be able to make that hopefully definitive diagnosis. Typically these are follow-ups after this positive screen. There is a blurring of the distinction between these kind of tests recently. And one reason for that is two of the major ones are amniocentesis and chorionic villus sampling, CVS, amnio and CVS. So these tests are getting better as time goes by. And as they get better, the risk for these tests is going down as well. So it's becoming much more common that these tests, amniocentesis or CVS, are being offered to all pregnant females regardless of risk. I'm not sure that I agree with that necessarily, but that is the direction that things are going. Like the American College of Obstetricians and Gynecologists, they offer screening guidelines. So essentially kind of trying to say, this is what we recommend in terms of how you would work with these patients. And they now recommend that this be offered to all pregnant females regardless of risk. The idea of amniocentesis and chorionic villus sampling. And hopefully, the educational component is coming along with this. Because I think without that educational component, this is not necessarily a good idea. And again, it's up to the female, the couple, in terms of the decision of whether or not to have that test at all. It's not the decision of the physician. So the best tests of this type are isolation of the fetal tissue, being able to directly analyze cells from the fetus. And so amnio and CVS are the two most common. So this is for amniocentesis. And amnio involves the insertion of a very long needle. So if you don't like needles, you probably don't want to see an amniocentesis. And if you don't like needles, maybe this is the wrong profession for you anyway. But essentially, the needle going in with ultrasound guidance. And this is where this method has improved because ultrasound has gotten much better too. Ultrasound guidance going into the amniotic sac. Not puncturing the fetus in any way, but simply drawing amniotic fluid. Removal of about 20 to 30 milliliters of amniotic fluid. That fluid contains the amniocytes. Amniocytes are cells that are shed by the fetus into that fluid. So by isolating the fluid, you get cells from the fetus. The window for this, and I think having a sense for the window of opportunity for these kind of tests is important. The window is 16 to 20 weeks LMP. And LMP is the last menstrual period. That essentially represents kind of the 0 point in terms of counting, is the last menstrual period. So 16 to 20 weeks after the last menstrual period is the window where amniocentesis is available for a pregnant female. Then, once we isolate this amniotic fluid, there are tests on both the cells that we isolate and the fluid. So FISH analysis, for example, is one possibility that you could do on the amniocytes. And I showed you that earlier in terms of looking at that. CVS. One thing I want to point out is one, to help you remember this, is notice the fetus in this particular image with amniocentesis and then with chorionic villus sampling. Smaller. And so CVS is earlier. CVS is an earlier test than amniocentesis. So CVS can be done transabdominally or it can be done transvaginally. And essentially what we are doing in this particular case is isolating extraembryonic portion of the blastocyst. So essentially tissue not from the fetus itself, but from the placenta. And again, ultrasound being really important to do this accurately. This is done in the window of 10 to 13 weeks, LMP. So CVS can be done earlier than amniocentesis can be done. Advantages, disadvantages. One is earlier diagnosis with CVS could be advantageous, especially for those females or couples where pregnancy termination is an option for those individuals. Earlier diagnosis can be better in those cases. For amniocentesis, getting amniotic fluid is an advantage of amniocentesis. And I'll talk about what we can do with the amniotic fluid a little bit later on as we go through this. But getting that amniotic fluid can be beneficial. CVS, since it isolates extraembryonic tissue as opposed to embryonic tissue, there can be times when there are differences between the extraembryonic tissue and the embryo itself. So you could have, for instance, mosaicism within the extraembryonic tissue that may or may not be present in the fetus. You don't know for sure. you know that the extra embryonic tissue is mosaic. Is the conception mosaic? Don't absolutely know. You can also see different, if both are mosaic, different ratios in the extra embryonic tissue versus the conception as well. So you don't get absolute full information from that kind of analysis. The risk for both of these procedures is pretty similar. It used to be that CVS had a higher risk than amniocentesis, and so that was an advantage for amnio. But nowadays, with current technology, there's very little difference in terms of risk between these two. So what is the risk? And this is the current risk, and this is a number that is probably constantly changing as these procedures get better and better. And so certainly keep that in mind. That say 4 or 5 years from now, these numbers could be different. But these are the numbers as they stand right now. The best way to look at this is to look first at what is the normal background for loss of a conception in the window of CVS or amniocentesis. So CVS in the 7 to 12 week window has about a 2 to 5% risk. So what that means is that about 2 to 5% of all conceptions are lost in that particular window of time. CVS, or in amnio, at 16 to 20 weeks, the background goes down, is lower, and it's about a 1 to 2% risk at that time. So that's the background for all pregnancies. Both amnio and CVS have about a 1 in 300 to 1 in 500 risk for inducing pregnancy loss. Meaning that if we take the average of this, for every 400 of these procedures that is done, one of these results in loss of the pregnancy as a direct result of the procedure itself. So that's a number that is important to relay to individuals as well. There is a risk associated with this. The risk is low, but this is approximately what it is. So that represents about a 0.2 to 0.33% increase over background. And these can be valuable numbers to do as well, is to say, all right, if it's chronic chorionic villus sampling and we say it's about 1.5%, then it's maybe about 1.7, 1.8% risk if we do amniocentesis as well. So the risk is low, but there is a risk that is associated with it. And the primary risk is loss of the pregnancy as a result of the procedure. Okay, this is shifting gears a little bit. Any question on any of that content thus far? Okay, so pre-implantation genetic diagnosis. As it implies, we're making a genetic diagnosis prior to implantation of the embryo. 2 important steps. First one, in vitro fertilization occurs. And then testing of embryos that are derived from in vitro fertilization. This is an option for perhaps individuals who are opposed to the idea or do not wish to do pregnancy termination after genetic screening. It's an expensive option. One of these procedures is probably in the range of $40,000 to $50,000. And they don't come with any guarantee either. So it's entirely possible that you don't get implantation after this procedure occurs. So do you do it again? So every time, $40,000 to $50,000. Covered by insurance? Right, sure. So typically an option when a known or very serious genetic disorder is possible in a conception, where we could say there's a 50% chance that if you have a pregnancy, that it will result in spontaneous pregnancy loss, for example, which is pretty high. So how does this work? First, we do in vitro fertilization, essentially fertilize the zygote in the test tube, not in a test tube, but in a petri dish. Then we allow that fertilized embryo to grow in vitro to about the 8-cell stage or the 16-cell stage. At that point in time, we come to the embryo, and it says we do a biopsy. we remove one of the cells with a microneedle, going in and taking out one. So if it's a 16 cell, then it's a 15 cell blastocyst. If it were me, I would much rather have 15 than down to 7, but apparently there's very little risk associated with the removal of one of those cells. That single blastomere is then tested, one cell testing, and asking for the disorder in question. Is it present or is it absent? So essentially then, we can assess these and say, okay, this one does not have the mutation, if it's a particular mutation we're looking for. This one does have the mutation. We don't implant this one. We do proceed with implantation of the one that's negative. So only those embryos that test negative for the particular disorder are typically candidates for implantation. And an example of this is Tay-Sachs disease. Tay-Sachs is an autosomal recessive disorder. It is a neurological disorder. It is 100% lethal. And it's typically within the first 4 years of life. These infants that are born with Tay-Sachs, they appear perfectly normal at birth and then gradually decline. It is a lysosomal storage disorder, and the neurons essentially degrade over time. And it is a terrible thing to witness, the loss of neurological function as these children age. And 100% of Tay-Sachs children do not survive past 5 years tops. No treatment and no cure for this disease. So this is a death sentence within 4 to 5 years. If parents are heterozygous with any autosomal recessive, there's a 1 in 4 chance of having a Tay-Sachs child with every pregnancy. And there's a 1 in 2 chance of having a child that's heterozygous. So this would be an example where pre-implantation genetic diagnosis would be a feasible possibility. Test those embryos, looking for homozygous unaffected embryos. If you can't get one of those, then a heterozygous unaffected embryo, though I would say the homozygous is a better option. Proceeding with implantation, knowing, at least with higher certainty, that you're not dealing with a conception that could have Tay-Sachs disease. The risks. It is challenging, as you might imagine, to do genetic analysis on a single cell. Usually it's PCR-based, but it can be a real challenge. So the accuracy of this kind of testing is not as good as it is when you have lots of cells that you can isolate the DNA from. So the frequency of false negatives is around 1%. So a false negative is where the PCR test for Tay-Sachs came back negative, but the actual embryo is positive for it. Worst possible scenario. It's low, but it is present. So the risk is around 1% for a false negative. Another aspect of this is the controversy that exists with respect to what to do with embryos that you decide not to utilize for implantation. Do you discard those embryos? Do you keep them forever? What happens to those embryos that you have that you don't plan to implant? And so that's an additional complication. So, prenatal screening, 2 major components. The first one is ultrasound, examination of the fetus. So virtually every pregnancy has ultrasound. And then a second part is biochemical analysis, usually of maternal blood, for proteins and particular hormones that give us information. And I'll go into detail on each of these bullet points as well. There are new screening tools that I'll talk about as well that have the potential to really change how this type of prenatal screening occurs. So, ultrasound, I think you guys are familiar with ultrasound, so I don't have to go into detail in terms of what it does. But essentially, we are looking for fetal tissue, surrounding tissue, amniotic fluid, etc., with ultrasound. And there's lots of different things that can be diagnosed pretty accurately just with ultrasound alone. And this list here provides you with some of the indications that can be identified. So cleft lip, for example, can oftentimes be identified simply through ultrasound. Anencephaly, holoprosencephaly, oligohydramnios. What is oligohydramnios? Anybody know? What does oligo mean first? And oligo essentially means a few or a little bit. So oligohydramnios is in relation to the amniotic fluid. And so oligohydramnios is insufficient amounts of amniotic fluid. There are some, let's see, autosomal dominant polycystic kidney disease is a disorder where the amniotic fluid is especially low. That, hopefully you could figure, is going to be problematic for conception, not to have enough amniotic fluid. So many different things can be detected with ultrasound. This is an example where we're looking at essentially the neural tube, a normal neural tube, and then a conception that has a meningeomyelocele sac, essentially a neural tube defect, and that neural tube defect being identified through ultrasound. Here's another one. This one is called Holt-Oram syndrome. This is a normal ultrasound. Here is the hand, the arm, humerus, radius, ulna, and then the other assorted things that are connected to the arm. And then this is a conception with Holt-Oram syndrome. And you can see there's 3 digits here, and there's 1 digit here. And so there are only 4 digits, and this digit seems to be especially large as well. This is the OMIM site for Holt-Oram syndrome. It is an autosomal dominant disorder. A number of different features, but a major one is skeletal. So the limbs are oftentimes affected. One of the things we see here is a triphalangeal thumb. And essentially what that means is that the thumb is oftentimes has more the appearance of one of the other digits. Instead of 2 phalanges, it has 3 phalanges. And so that's what we would see here, where you'd be hard-pressed to know which one of these is this thumb, essentially that one. And then we can also see absence of the thumb as well. Can be detected with ultrasound with pretty high accuracy. The next part of prenatal screening is going to be alpha-fetoprotein screening, so AFP. AFP is a protein that is expressed during embryonic development. First, it's expressed in the yolk sac. And then later, once we have a functional liver, the liver of the fetus takes over and produces alpha-fetoprotein. And it's very similar to albumin in terms of its function. It's a carrier protein and carries a number of other different molecules, similar to how albumin does that in an adult or a young child. AFP in the amniotic fluid is normally highest in the first trimester, and then as the pregnancy continues, it goes down. And so there's a curve in terms of AFP in the amniotic fluid. Why is it in the amniotic fluid? And a reason why it's in the amniotic fluid, even though it's being made by the liver, is that when the neural tube is still open, then the neural tube has essentially, or the amniotic fluid and the neural tube have free access to each other, if you want to call it that. So once the neural tube closes during embryogenesis, then the release of amniotic fluid declines. And so that's why it goes down, is closure of the neural tube. So one of the major things with alpha-fetoprotein screening is if there's failure of the neural tube to close, spina bifida, in other words. Failure of the neural tube to close will cause chronically high levels of AFP in the amniotic fluid. And that's something that we can test for if we have amniotic fluid. So AFP screening is always done whenever amniocentesis is done. And I mentioned this is one of the limitations of chorionic villus sampling, is that we don't get amniotic fluid when we do CVS. I'm out of time. I think that ends that slide. So I will stop there, and we'll continue in like 10 minutes talking about MS AFP. Sorry, I went a little bit over. I lost track of time.